Hello and welcome back everyone. So continuing our discussion about the pediatric medicine, in this video we will talk about the foreign body aspiration, which is also referred to as airway foreign body. And this is when a foreign body, which could be a food particle or an object, enters the airway and either sit in the larynx or beyond in the trachea or in the bronchi. And airway foreign body is a leading cause of morbidity and mortality among children, especially older infants and toddlers, which account for 60% of all airway foreign body cases. Now, males are 1.7 more likely to be affected than females, and in infants younger than 6 months, the cause is usually secondary to feeding by a well-meaning sibling. So that is usually a sibling that is older and tries to feed the infant, and this would lead to foreign body aspiration. Now, most common aspirated foreign bodies are food items, which account for 70%. Examples are nuts, seeds, bread and meat, hard candy, gum, bones, raw fruit, and vegetables. And common inorganic objects aspirated, which account for 30%, are coins, latex balloons, pins, jewelry, magnets, pen caps, and toys. Now, globular, compressible, or round objects such as grapes, meat, and bread, nuts, balloons, marshmallows, and candies can block the airway completely, so they are very dangerous to children. Now, unlike inorganic objects, aspirated vegetables commonly causes intense pneumonitis and subsequent pneumonia and suburative bronchitis. Now let's talk a little bit on why children are affected by foreign body aspirations. So young children are more at risk to aspirate a foreign body because they often use their mouth to explore their surroundings, and they are generally more likely to be distracted, playing, or ambulatory while eating, and this would lead to aspiration. And young children are more vulnerable to choking because they have a smaller airway diameter than adults. Now let's talk about the clinical features of foreign body aspiration. So the clinical features are variable depending on the type of the foreign body and the duration and the location of the foreign body within the respiratory tract. And clinical features ranges from asymptomatic to severe respiratory distress, and the most serious complication is complete airway obstruction, which manifests in the conscious child as sudden respiratory distress followed by inability to speak or cough. Now, foreign body aspiration results in symptoms divided into 3 stages. So the first stage is the initial event, and this will manifest as paroxysms of coughing, choking, gagging, and maybe airway obstruction occur immediately after the aspiration of the foreign body. And sometimes the child expels the foreign body during this stage. The second stage is the asymptomatic interval. In this stage, the foreign body becomes large, the reflexes are fatigued, and immediate symptoms will subside, and lack of symptoms in this stage is deceiving, and it would lead to delayed and missed diagnosis. In the third stage, the child would develop complications, and those include airway obstruction, erosions, pneumonia, and atelectasis develop, which will manifest as fever, cough, hemoptysis, etc. Now, a foreign body aspiration should be suspected if there is a history of sudden onset of coughing or choking, and should be considered in all children with unilateral wheezing. Now, at presentation, many patients are in the asymptomatic interval. Now let's talk about the classification. So, foreign body aspiration is classified into laryngotracheal foreign body and the bronchial foreign body. Now, in laryngotracheal foreign body aspiration, the patient presents with stridor and hoarseness, and in the bronchial foreign body, the patient presents with unilateral wheezing and decreased breath sounds. Now, wheeze may be present in 30% of laryngotracheal foreign body aspirations, and stridor is present in up to 10% of bronchial foreign body aspirations. So there is some overlapping with these symptoms. And 80% of foreign bodies are in the bronchi, and patients with immediate onset of severe stridor and cardiac arrest usually have laryngotracheal aspirations. Now let's talk about the diagnosis. So bronchoscopy is the gold standard for diagnosis and removal of the foreign body, and history is the most important factor in determining the need for bronchoscopy. A positive history must never be ignored, but a negative history can be misleading because foreign body aspiration can be missed and confused with more common causes of respiratory diseases, because patients may have fever, wheezing, or rales. Now, child caregivers should be asked about nuts and seeds because they are the most common airway foreign bodies, and examination of the nose, the oral cavity, the pharynx, and lung sounds is important. Now, radiology also important. Plain X-rays are the first line, and inspiratory posterior-anterior chest X-rays is ordered first, and expiratory or lateral decubitus films can assist in diagnosis. Now, 90% of foreign bodies are radiolucent and not seen on X-rays, but secondary findings such as air trapping, asymmetric hyperinflation, obstructive emphysema, atelectasis, mediastinal shift, and consolidation, all important in identifying the location of the foreign body. Now, this picture here shows a PA chest X-ray of a child who aspirated a peanut, and you can see that the left lung here is hyperinflated. You can see that the diaphragm is down and it's a flat diaphragm, so this is a hyperinflated lung. And you can also see that the mediastinum is shifted to the right. You can see the trachea is shifted to the right, and this is all because of the hyperinflation. So this means that there is a foreign body in the bronchi here. So there is a foreign body in the left bronchi here, and it is not obstructing the bronchi completely. It is obstructing the bronchi partially, and it is allowing air to enter the lung, but it is not allowing the air to escape from the lung. So it is acting as a one-way valve, causing hyperinflation of the lung. So the peanut is acting as a one-way valve, and it is causing hyperinflation and preventing the air from escaping from the lung. Now, on this picture here, we have a PA chest X-ray, and it is showing hyperinflation of the right lung here, and this is for a child who aspirated an apple piece, and you can clearly see that the trachea is deviated, the mediastinum also deviated to the left, and you can see that the right diaphragm is flat, means there is hyperinflation of the right lung, and this is because there is a foreign body in the right bronchi, and it is also acting as a one-way valve. It is allowing the air to enter the lung, and it is not allowing the air to escape, leading to hyperinflation and mediastinal shift. Now this picture here is for a child who aspirated nails, and you can see the nails are sitting in the bronchi and they are not causing pneumothorax or atelectasis. So they are just sitting there in the bronchi. Now CT scan has no role in airway foreign body diagnosis due to radiation risk in pediatric population, although it is highly sensitive and specific and able to detect radiolucent objects. So if there is high index of suspicion, despite negative or inconclusive imaging, bronchoscopy should be done. Now let's talk a little bit about the upper esophageal foreign bodies. So upper esophageal foreign bodies are usually radio-opaque and can impinge on the posterior aspect of the trachea, and when they impinge the posterior aspect of the trachea, they would lead to stridor. So patient present with stridor and typically have dysphagia. So they would confuse you into thinking that they are in the airway, while in reality they are in the esophagus. And radiographically, the flat foreign bodies, such as the coins, are usually oriented in the sagittal plane when located in the trachea and in the coronal plane when in the esophagus. So as you can see in this picture here, so this is for a child who swallowed a coin, and you can see that the coin is oriented in the coronal plane, and this means that the coin is in the esophagus. Now let's talk about the treatment. So if foreign body aspiration or airway obstruction is clearly present, you perform the basic life support procedures to relieve the airway obstruction, and this will consist of back blows and abdominal thrusts. And if the BLS maneuvers fail, perform direct laryngoscopy and extraction of the foreign body with the magill forceps. And the magill forceps is shown here. You can see that the magill forceps give you an angle to work with, so it is easier to remove the foreign body from the trachea. And if the foreign body cannot be seen, orotracheal intubation with dislodgement of the foreign body distally may be life-saving. So you try to intubate the patient and you push the foreign body backwards. Now, if obstructive laryngotracheal foreign body cannot be removed or dislodged, an emergent surgical airway may be required, and definitive treatment of partial airway obstruction caused by the foreign body usually require rigid bronchoscopy in the operating room under general anesthesia by an otolaryngologist or pulmonologist. And complications of rigid bronchoscopy include bronchospasm, bleeding, and airway edema. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support more, you can by joining the channel. Link will be in the description of this video. Thank you for watching, and peace.